Hi, my name is Sonalini Matthew. Today I'm in conversation with Dr. E.S. Krishnamurthy. Dr. Krishnamurthy is a neuropsychiatrist based out of Chennai in India, and he's first going to tell me what a neuropsychiatrist does.
Yes. So, a neuropsychiatrist is somebody who falls in the interface between neurology and psychiatry. And one thing that most of us don't readily recognize is that we don't really have a physical organ called the mind. And the organ, therefore, that really is the mind is the brain, and that's the working brain. And of course, that's the basis of any biological theory of mind. But if you go beyond that, when your brain malfunctions, so does your mind. And therefore, when you see in children, for example, you can have various developmental disabilities, cerebral palsy or mental retardation, what we now call intellectual disability, or epilepsy or autism. In all those circumstances, there are neurological features, there are also mental health features, and you see that combination. In the same way, as people get older, you can see how brain injury of any kind can cause mental health symptoms. So, for a very good example is traumatic brain injury after road traffic accidents, where people then end up having, apart from physical disability, which is very neurological, they have cognitive disability, which is to do with memory and attention and thinking, but they also have behavioral problems, which are quite prominent. Similarly, epilepsy, especially when it's severe or when it is frequent, it comes with a host of cognitive and behavior problems. And this follows itself then into, as we get older, into stroke, into Parkinson's disease, into dementia. In all these circumstances, the patient has neurological symptoms, they have psychiatric symptoms, and they need to see both kind of doctors. A neuropsychiatrist is someone who comes, or a behavioral neurologist, some people are called cognitive neurologists. They come from one domain, either psychiatry or neurology, and then they do a fellowship in this particular interface area. Which then helps them work with people who have problems which are a little more focused on this particular interface.
So, which background do you come from? The neurological background or the psychiatry background?
So, I actually trained in psychiatry, I trained in neurology, and then did a 4-year fellowship in behavioral neurology and neuropsychiatry. So, I'm one of those few people who's bang in the middle. Most people are oriented in one direction or the other.
Right. So, you have also been the past president of the International Neurological Association.
Neuropsychiatric Association, yes.
I'm going to do that again.
Okay.
So, you've also been a past president of the International Neuropsychiatric Association. What does this association do?
So, we are interested in the field of neuropsychiatry, and we bring together neurologists, psychiatrists, psychologists, neuroscientists, people from across disciplines who work with people who have neuropsychiatric conditions or are involved in the research of neuropsychiatric conditions. And like all academic associations, it's a platform for people to come and discuss and talk about their research, to collaborate, to teach others, other professionals who want to learn about neuropsychiatry, to help people improve their practice or set up a whole service, and so on. So it's a lot of interaction for research, for teaching, for clinical care that the association offers as a platform.
Okay, great. So today we're going to talk about integrative health for adults, specifically for adults with neuropsychiatric disorders. So I'm going to start with an incident from work. We had a colleague who never met any of us in the eye. He kind of looked away each time we tried to, and was often labeled weird, strange, shifty-eyed, right? But when I worked with him for a year, I realized that when you gave him a task which was repetitive, he did it very well. and he never missed it, ever. But if I needed him to do a job that required joining some dots, he couldn't do it very well. How many of us simply don't get diagnosed?
So the interesting statistic is that when they have gone to in schools and colleges and looked at how frequent it was for someone to have, say, dyslexia of some form, or indeed to have any form of mild intellectual impairment or slowed cognition, the numbers have been as high as about 20% in some studies. Okay, so between 1 in 6 and 7 of us probably have some problem which we are coping with. Now, from what you tell me, obviously your colleague was someone who managed to function at least at a basic level and got a basic level of education, because otherwise he wouldn't have been in the job. Right. But then of course the problem showed up in some way in his case, and in his case it showed up that he was good with repetitive tasks, but he could not do anything that needed him to exercise his imagination or connect the dots, as you called it. And I think that's not uncommon with people with various forms of developmental disabilities. They do things repetitively well, and sometimes, in fact not sometimes, very often they are very, very diligent once you give them something to do. But on the other hand, they find it difficult to do anything that is creative, imaginative, requires them to think about a few steps and so on, the planning, execution kind of components. There are other reasons why someone does not meet your eye or is sort of shifty-eyed as you thought he might have been. One is, of course, a lack of confidence, what we call social anxiety. And there's a very large number of us out there who are socially anxious and find it very difficult to engage with somebody new. It gets better the more familiar we get with a person, the better we are in engaging with that person. We are usually okay with small groups, familiar people, but the moment it's a large group, the moment it's new people, the moment it's getting up on stage, we get into challenges. So that's social anxiety. When I start avoiding social situations altogether, that's social phobia. Okay, so that's one of the reasons why people don't make eye contact. And of course, people in the autism spectrum, and sometimes you have high functioning adults in the autism spectrum who are awkward, geekish, and who will not make eye contact. So those are all reasons also why people don't make eye contact. And of course, the third reason could sometimes be something more serious like schizophrenia, where the person has imaginations or belief systems that are working, which prevents them from engaging normally with other people in some way. So all these are possibilities when you have someone in your environment who is struggling. But in all those instances, actually there is hope, and people can be helped if the problem is identified.
So if someone does not fit the mold, do I need to, as a family member, do I need to be concerned? Do I need to bring them to you?
Yes. So, one thing that you need to think about, what does something as subtle as this do? A member of your family who is not able to make eye contact, who can work only in a limited way, it limits the individual, his or her potential and his or her opportunities. So it's very important to know whether something can be done. And I'll give you a very simple example. There's something called social skills training that therapists do, where we help people become less anxious about social settings and help them engage better in social settings. And even people with various forms of intellectual and developmental disabilities can actually do this. So we have one young lady, for example, who's gone from being terribly shy. She is intellectually disabled. One of her main problems was social anxiety. And she's gone from being terribly shy in the context of social situations to now being quite gregarious. And she's actually working in a cafe, and she actually takes orders and talks to people and takes care of them. So, and that was done through quite a prolonged period of work. Her parents were very obviously diligent too. They were the ones who brought her to us. It took us quite some time, and it involved exercises like the therapist actually going with her to the supermarket and saying, now you will go up to the counter and ask for this. Or going to the metro and saying, let's board the metro together. And, you tell me when we are going to get off. And so on. So, in a sense, you can actually work with people in various ways to make them better. And therefore, it's very important actually that you try and bring them to the attention of a professional.
So is it like training your brain, much like you're training your body for, say, a marathon?
Absolutely. It's training your brain in a certain way, because your brain is capable of building new pathways and new skills. And also training your mind to accept that this is not a dangerous situation. I need not be anxious about this situation. This is as easy as a piece of cake.
Right.
And if you dial back to, say, the first time you spoke to a group of people, and think about how nervous you were and how much you had to practice. And if you then dial forward to having done it a few times to now, and how nervous you are now and how much you have to practice, there's a huge difference. It's just doing something repeatedly makes it so much easier for all of us.
Right. How much of trauma that we faced in childhood actually builds up and is reflected in the adults we become?
Great question. I think we carry childhood trauma in some subtle ways all our lives.
What does childhood trauma do to the adult that we become?
I think childhood trauma has potential to have a huge impact and very lasting impact. There are two broadly ways in which it reveals itself. One, of course, is obvious, where I myself make the conscious connect between what I went through in childhood and what I am finding difficult now. And we do see clients who are able to make that connection. They talk about their traumatic childhood. They talk about traumatic childhood experiences. They talk about how that's impacting on them today. Right? And a classic example would be, say, an authority figure that you had to deal with in childhood constantly and wasn't very pleasant to you at all, and how you find authority figures difficult even today as a working professional or as an adult who is having to function. The other type is a lot more unconscious. In a sense, you don't really remember the trauma in detail in the way that it was vested upon you or what you experienced. You may remember parts of it, but you don't remember the extent of it or the depth of it in your conscious mind. And yet it's had huge impact, so much so that when you get into situations which are in some way akin to those traumatic situations, either the people or the dynamics or the environment reminds you in a very latent way, subliminal way about that traumatic situation, you then tend to react in ways that may not be entirely understandable or appropriate. And one of those examples is, of course, childhood abuse, where people carry this within them for a long time, and it has a role to play in many things in their life without them realizing it, both in errors of judgment and in terms of avoiding things that they really should be engaging in, both.
How do you even tell somebody that they have had childhood trauma? Because often you'll find adults saying, yeah, my parents used to beat me quite regularly, but in those days that was the way of disciplining. So
in a sense, what's, the Goose and Gander difference. In a sense, if I have internalized it that way and I appear to be comfortable with it, that was it was a representation of the time that I grew up in, and everyone did it. I'm not perhaps particularly traumatized. I found an explanation. I found a way of dealing with it or coping with it. So much so that I'm not blaming my parents or I'm not feeling bad myself and so on. So that's entirely possible that people go through what today would be considered traumatic experiences, but in some contextual way were okay in the time that they grew up and they've internalized it that way.
Right.
On the other hand, if it so happens that you continue to feel bad about it, or if it so happens that you continue to have unexplained psychological feelings of unhappiness or distress when you either come into like situations or, I mean, I'll give you a very good example. I had a child today who is clearly a very smart kid, slightly hyperactive. And the father, who clearly also shares some of those traits, was very, very keen to make his point that it's okay to be like this and we don't have to fix it. So in a sense, he obviously has struggled with it as a child and the way he was dealt with by other people. And he's now, it's leading to him in a very latent way being protective about his own child. So I think when you ask about how our childhood influences shape us, traumatic or not, I think they do. In a very significant way, they can actually shape us.
All right. Besides any kind of psychological trauma, there's a lot of trauma that happens during impact sport as well, right? Physical trauma. We don't even consider it as significant. We don't even think about it. How important is that to take into consideration for certain adult behaviors?
So in fact, we've learned now what boxing does to your brain. And boxing actually, in someone who boxes, especially without protective gear, boxing actually leaves a hole in the brain or holes in the brain. Okay, so we do know that there is a very long-term impact of boxing on the brain. The same thing applies today. We believe that football has potential to do the same thing, especially the more contact forms. I'm not talking about soccer type of football, but I'm talking about American football or rugby as they play it in the Commonwealth. These are high-impact sports, and these are sports where you can sustain head injury. And not once, but repeatedly in a mild fashion. So there is long-term impact, cognitive impact, and perhaps behavioral, emotional impact of having these injuries, over time. And one therefore cannot afford to, neglect it. Now, how does one, as a professional, how do I zero in on this? It is when a person presents to me with problems in later life, and then I take a history and I ask, what did you do? And then I come to know that this was what they were doing. And in some ways, playing a sport of that nature, a high impact or a contact sport of that nature in early life, is similar to having a history of occupational exposure to a toxic substance. Or indeed anything else. So it's about asking them whether they've done any one of these things, and then obviously taking that on board.
So your history taking must take a very long time, perhaps even up to an hour or more.
Oh yes, and of course you get better at it and faster with it as you get more experienced as a professional. But history taking is about the most important thing that most of us can do in this specialty. Famously, a very famous physician once said, "Listen to the patient, he's trying to tell you the diagnosis."
How much of traumatic brain injury do you see in your clinic? And you'd mentioned that that can be quite difficult because it's both physical and mental and emotional. There's a whole lot going on there. How do you deal with it at the Buddhi Clinic?
Traumatic brain injury is one of the more difficult things that you have to deal with, because you're left with somebody whose brain is potentially damaged. So let me tell you a patient story. This was a young IT professional in his 30s who was in a road traffic accident and had a fairly serious injury to the front of his brain in that accident. He was operated upon. He was deeply unconscious in a major hospital for several weeks. And finally, when he got discharged from hospital, he was in a confusional state, a delirium. He was aggressive, violent, and he actually had to be tied to a bed in order to keep him quiet, because otherwise he would run around all over the place and he would actually get into altercations with people. He didn't even know what he was doing most of the time. So that was the level of disability he was left with. He had no memory as to who it was in front of him, didn't recognize his parents, didn't recognize his wife, didn't recognize his business partner, anyone. So that's the condition he came to us in. And it took us a good part of 2 weeks to sort of calm him down and get him to a point where he could sit across a table and engage with us. Now, the happy story is that working with him over several weeks, we actually managed to return him to work. And he's actually migrated back to the UK to work as an IT professional now and is holding his job there very well. So that was the good part of the story. But what did that take? He needed a full course of brain stimulation sessions. He needed several sessions of cognitive retraining with a psychologist. He needed, his family needed several caregiver support sessions for them to understand how to work with this guy. He had sessions of Ayurveda, naturopathy and yoga, which helped him calm down, help improve his sleep, improve his lifestyle. He needed physiotherapy because he had physical disability. So in a sense, this man needed something like 200 hours of therapy. But the good news was at the end of that, he went from being completely dysfunctional, the way I described him, to somebody who's able to go back to work and who's able to lead a very normal life. Now, this is what happens to a lot of people with traumatic brain injury, and many of them do not get this kind of comprehensive care. Many live with disabilities which they assume they have to. So I actually met someone a couple of days ago who works on an oil rig and has had a traumatic brain injury while working on the oil rig. And he's had persistent symptoms concerning his vision, concerning his moods, concerning various other aspects of him for the last 2 years. It was not a major head injury in his case. It was a minor head injury, but it's left him with a fair amount of disability and he's working with difficulty. He's managed to hold on to his job with difficulty. And the number of people you'll meet out there who've had minor head injury, like this gentleman I'm talking about, and who are left with problems which they don't seem to be getting over, which become real bugbears for them, is very large. So there needs to be an awareness, because we are the road traffic accident capital of the world. And there needs to be an awareness that there will be problems for a lot of people after traumatic brain injury. Something as simple as why brain injury, something as simple as a whiplash. I meet people who are symptomatic 15 years later, ever since I had my whiplash, doctor. So that's how problems can be after trauma, physical trauma. And they do need to be recognized. And the good news is you can actually help a person.
That's wonderful. What is brain stimulation? You mentioned brain stimulation. What is brain stimulation? How do you do it and why do you do it?
So many years ago, there was a kind of science called phrenology, which was to do with measuring people's skulls and deciding what type of person they were. And why I'm mentioning that as a start is that phrenology was something that got to the fairs in the early part of the last century, and it became the classic hocus pocus. Okay. So a lot of people end up thinking any form of brain stimulation is hocus pocus, and it's not. We stimulate the brain with several different types of, technologies. And these are now called the new neurotechnologies. In fact, we've had a whole conference of the new neurotechnologies because there are so many of them. The most prominent of them that is in use extensively is called transcranial magnetic stimulation, which is delivering a strong magnetic impulse, usually to the front of the brain, in order to stimulate various brain pathways. Now, this is FDA approved for conditions like depression and OCD, and there are research protocols for a number of other conditions as well. The other type of brain stimulation is called transcranial direct current stimulation, where you use a small current, and this is not ECT or shock therapy. This is just a small current going between an anode and a cathode. Again, specific brain regions are stimulated for specific conditions. And we have other forms of brain stimulation. There are types of brain stimulation like deep brain stimulation, where you actually implant the stimulator inside the brain. And you have you implant the electrode inside the brain, and you have a stimulator implanted within you, which is then adjusted, and it keeps stimulating your brain. It's a very important treatment today for Parkinson's disease. Another new exciting area of technology is for people with purely controlled seizures, where the stimulator is the type of stimulation, it's able to identify that the person's going into a seizure, it gets activated, it stimulates the brain and suppresses the seizure. Okay. And we have here another type of stimulation which is not to the brain, but is to the vagus nerve. The vagus nerve is the one nerve that connects the brain. It's a cranial nerve, so it connects the brain to the rest of the internal organs in the body, and it has a lot to do with, for example, the gut. And this stimulator takes advantage of the fact that there's a branch of the vagus nerve that comes to the ear, and therefore it stimulates that branch. This is called transcutaneous auricular vagus nerve stimulation, TAVNS. So we have a host of technologies today that we can actually employ on people with neurological and psychiatric conditions, which have potential to help them. In the particular case of the man with traumatic brain injury, what helped him was transcranial direct current stimulation. There's a particular protocol for mood and behavior which helped him. We have a protocol for delirium that we've used for a number of people with post-COVID delirium, and it's been supremely helpful. We have a protocol for cognitive enhancement, which we use in a lot of people with mild cognitive impairment or early dementia, and that's very, very helpful to them, and so on. So,
there's this phrase called an assault on my brain, and we often talk about it in the context of sounds that are too loud. Is it possible that just living in a city with all the traffic sounds and with all kinds of really an assault on your senses, can it actually be traumatic?
Yes, definitely, especially for certain groups of people. So there are people who, by virtue of their neuropsychiatric state, are hypersensitive to various senses. Noises are what you're talking about, but people can be hypersensitive to light, for example. People can be hypersensitive to touch. People can be hypersensitive to temperature. So there is that. The other, of course, is that when you get too much of stimulation, that does have an impact on things like your circadian rhythms, and it will affect your biological rhythm, it will affect your sleep, and so that also has potential to make you unwell in the long term. So you're absolutely right that urban living comes with some challenges.
The people who are impacted more by this sort of thing, are they right-brained usually?
Don't think we have very clear evidence of that one way or the other. No, okay. Not that I can think of, no.
Okay. There's so much been spoken about stress and anxiety and depression, and these don't develop overnight. There's a lot of erosion that happens, right? But often when you look at social media, they'll tell you, eat healthy, sleep well, exercise, and you'll be fine. And it seems to a person with depression to be very shallow advice, though it's not incorrect. How would you at your clinic go beyond those 3 or 4 things that seem to be like this? I would perceive them as almost band-aids, right, for somebody with deeper problems.
Absolutely. So the first thing is to try and understand, the basis of mental health. And the World Health Organization calls it psychosocial. Okay? The biological processes that make us vulnerable to mental health conditions are no different from other biological processes. So to give you an example, some of us are born with a vulnerability to diabetes, some of us to hypertension, some of us to heart disease, some of us to certain types of cancer. Some of us are born with a vulnerability to mental health. So the way you're wired does confer upon you a certain vulnerability, or of course not. Okay. Then the psyche is, in my view, the sum and substance of life experiences, and we've talked about this a little bit earlier. We have experiences which are positive and nurturing. We draw upon them later on in life. They become positive role models to us. We have experiences that are traumatic, and we were talking about trauma a little earlier. And trauma leaves you with scars. Trauma leaves you with things that make you vulnerable to stress in the future. And then, of course, you have the social circumstances. So we do know that people in stable relationships have some protection from stress. We do know people who have economic stability have some protection from stress. We do know that if you have purpose in life, a job or education or people to care for, then that gives you some protection from stress. So when you do experience symptoms of anxiety, depression, and what we loosely call stress, it is because there is an element of vulnerability, there is a gap in the psyche that's permitting it at some level, and then there is this social factor that has impacted, something that has stressed the system. And that's when you start experiencing symptoms. So if I said to you, only one thing will help you, change your lifestyle, it will help you, it's probably not going to be true for the vast majority. The other mistake very often people make is, so I'll go to a doctor, I'll take a medicine. A medicine alone may not be able to help you. I'll go to counseling. Counseling alone may not be able to help you. So in a sense, what you do has to address the bio, the psyche, and the social. Then bring into this the stigma that is there in society. Bring into this the belief systems that we all live with, which become barriers to care or enablers to care. Okay. So at Buddhi Clinic, we have a whole host of things that we can offer someone with a mental health condition. Okay. They come in, they have an assessment, we help them understand their biopsyche, social. We then talk to them about what might help them. And medication, some accept, many don't. Psychotherapy, many accept, some don't. Brain stimulation, many youngsters are very keen to do it, many older people are not. So that's just interesting. Ayurveda and yoga, many older folks are very happy to do it. Youngsters are not as all-embracing. So in this sense, when we have a basket of about 15 things that can help people, we also give them the option of choice. We also give them the opportunity to decide, okay, I will take this. So I had this young man who was so ill mentally that he would be found lying in front of the hospital one day, lying in front of the police station one day, and so on in his town. And his parents were at their wits' end. They were elderly and they didn't know what to do to help this man. And he refused to take medication. That was the conundrum. So when he came to me, I said to him, fine, you don't want to take medicine, but will you just do Ayurveda? And we have this procedure in Ayurveda called Shiro Abhyangam, which is a medicated oil massage for the head and neck. And he said, yes, I'll do Ayurveda. So he went on to do Ayurveda. And that's like a 21-day exercise that he's going through. Somewhere during the course of that, he came back to have a chat with me. And I said to him, I'll give you one medicine, will you take it? He said, yes, doc, one medicine I'll take. Because by that time, he had calmed down. He started sleeping well. He was in a more, equitable frame of mind. It was possible to engage him in that conversation, will you take medication? And I think that this is why an open mind helps. Because for him, a medicine as the first solution was intrusive. I don't think talking to someone would have helped him because he was very far gone. But he was able to see Ayurveda as a solution. He was able to accept it as a solution. And I was delighted to see that it could do for him over 20 days what a medicine could probably do over a 10-day period or whatever, but it didn't matter because it made him better. At the end of the day, this was someone who went from being non-compliant to compliant.
Right. But it's not just about choices, right? You're also putting the power into my hands.
Absolutely. Absolutely. And you can't be more right because, very often people talk about the placebo effect of treatments.
Yes.
And we have a lot of literature that is suggesting that about 40% of treatment effects are placebo effects. Okay? So we quibble about it. We are unhappy with it. I ask the contra question, why can't you be happy with it? If someone's getting better, how does it matter whether it's a placebo effect or a real effect? What matters is that it works, And I think that this is where I think we've become a little bit pseudoscientific in our approach to science itself. Right. That we are forgetting to see the humanism of it all. Because when I'm ill, what I want is to be well. I don't really care how. And I think that, of course, there's scope for a lot of charlatans to take advantage of that. But very honestly, systems like Ayurveda, systems like yoga, they have lasted centuries. Something that has lasted centuries can't be hocus pocus. There is a science behind it.
Yes.
In the same way, something like naturopathy, which comes from Europe, is now about 1.5 centuries old. So in a sense, I feel that this whole kind of willingness to thrash something because I don't understand it, not very helpful, because I believe that harnessing the power of different types of treatment is what will do wonders for our patients. And if I'm a sufferer, that's what I want. I want people to offer me choices. I want to be given the empowerment to choose through knowledge.
Absolutely. Now, personality disorders are being increasingly talked about, and they're seen a great deal more in an intimate partner relationship, isn't it? How does one tackle a personality disorder? If somebody in my family I feel has one, I'm not sure, do I come to you? Do I bring the person to you? How does that work?
So the first thing, of course, is recognition. In general, mental health, it's very hard to recognize that this is what this person is struggling with. I had a wife and husband, with the husband having a mood disorder today, and the wife said, for years I didn't understand what was going on. I didn't realize it was a problem. I didn't realize we needed help. So we finally went to a professional maybe 6 or 7 years after it all started. So even generally with mental health, recognition is difficult. With personality, it's even more challenging because it gets interwoven into your life. And it doesn't necessarily follow predictable patterns that you will recognize. A mood disorder in some ways is easier to recognize. This is much harder. It's much more subliminal. It is there on a daily basis in some way or the other. Okay. So the first thing, of course, is to recognize a pattern, and that this pattern is not okay. Okay. And the one thing I say about personality disorders is, if a person is very difficult to live with, that is usually a giveaway of a personality disorder. Okay. That not just you, but other people also say, yeah, man, I mean, that's quite challenging, isn't it? So that's usually a giveaway that this person may have a person, if not a disorder, a trait accentuation of some kind, that some personality traits are very accentuated. It shows itself in either being very superficially charming, but actually very cruel. It can show itself in being hypersensitive and paranoid about a lot of things. It can show itself in being very impulsive, fluctuant, and reactive in so many ways for things that don't require a reaction. It can show itself in being attention seeking. So, a pattern of behavior that clearly is causing some discord, is causing some discomfort, is very likely to be a personality disorder or trait accentuation. We divide them into 3 clusters in clinical practice. So the one cluster is people who are paranoid, or they tend to be very withdrawn, or they tend to have very magical ideas about life. The one cluster are people who are what we call explosive impulsive personality disorders, where they're either very attention seeking, or they're very unpredictable, or they have tremendous loss of temper, which is way over the top, and so on. And the one cluster is the anxious, avoidant, dependent cluster. This is the least complained about and the least bothered about. The first two, one good way to describe it to yourself is, am I having to walk on eggshells around this person? Or is it like walking on eggshells when I'm around this person? And if that feeling is there persistently, that I am actually feeling like I'm walking on eggshells all the time, then obviously you're dealing with a difficult personality disorder or not.
Right. OCD, or obsessive compulsive disorder. Are you seeing a lot more after the pandemic, or is it just being diagnosed more after the pandemic?
I think obsessions are, of course, repeated intrusive thoughts that a person has, which the person recognizes are irrational. Compulsions are what they do to make those thoughts go away. That's the very simple explanation.
Right.
Obsessions tend to be checking obsessions, cleaning, dirt. I can be obsessed about dirt and cleanliness. I can be obsessed about having imagery about aggression, or imagery about, say, blasphemy, religious figures, things like that. The difference is, I'm not fantasizing about being aggressive, or I'm not feeling impulsive about wanting to be aggressive. I'm afraid I will be aggressive. So there is a difference. Where the person who's got an obsession is not happy having that obsession. They are not kind of lending themselves into that thought process. Now, what's happened with regard to, of course, cleaning, especially dirt and cleanliness as obsession and compulsion, is, of course, that somewhere the pandemic normalized it. You were expected to keep things clean. So I know a lot of people who've been washing their vegetables, ironing their newspapers, wiping everything down, and so on. People even said, don't blow a candle on the cake, find out a way of putting off the candle on your birthday, and so on. So in a sense, the environment of the pandemic lent itself to one becoming fairly obsessive. And I was thinking about this myself yesterday, because in the past, when I was alone in the car during the pandemic, if I went to a crowded traffic signal, I'll put on my mask. Okay. And I had the impulse to do it yesterday, and then I said, I don't really need to do this anymore, But so the point, therefore, is that there is that gray zone today because of the pandemic. But yes, it has affected people. And there are people in whom the latent obsessive compulsive trait has become very, very prominent post-pandemic. There are people with existing OCD who've got much worse also during the pandemic. All of this is true. So in a sense, it's not an easy condition to be dealing with at this point in time. Is it more Probably marginally so because of the environment and the circumstances, but in general, these have been around a long time. I think the one other thing is our ability to recognize mental health problems has significantly grown up during the pandemic. And that's resulting, and that's a good thing, it's resulting in help seeking. One of the things that mental health experts are bemoaning is that the facilities are not multiplying in order to help people. That's definitely a problem. But definitely people's recognition has gone up. You asked about what do I do if I recognize a personality disorder in a family member, or I think a family member has a personality disorder. It's not very easy to get people to come to a doctor in these circumstances or even to a psychologist in these circumstances, but of course one should try. There are other strategies that one could employ which I recommend. Many people find it easier to go talk to a counselor, and if one says, for example, that look, we both seem to be having a problem, can we go meet someone? Not making it that person's problem but our problem. That might do the trick sometimes in getting someone to join you in coming to a mental health professional. That is one. The other is to just frankly make oneself the index patient. Go meet the doctor or counselor first. Tell them what all the problems you're seeing, and then let it be known to this person you're concerned about, who usually is a close family member. Let it be known that, I've started seeing someone. And naturally there'll be a curiosity, why are you seeing someone? And then somehow link it to their health and your concerns about their health, and get them to volunteer to join you on a consult. So sometimes that works better for people as well. So in sum, therefore, rather than point a finger and say you have a problem, you need to see someone, I think being more inclusive can be more successful in getting people to join you in coming to the doctor.
Kids with ADHD often grow up to be fairly well integrated into society. What are they doing right?
So there is this concept of Howard Gardner called multiple intelligences. And I think what really happens to children who grow up with a condition like ADHD, if they start blossoming, it's because they've identified their potential. They've identified what they do well. And that makes all the difference to them and how they blossom. So I think that's something to keep in mind, that we'd like to help people identify what they are instinctively good at and what they are naturally good at or gifted at, and help them bring that out in their everyday lives. And that is a clue in one way to all of us, that in the creative space, in the humanities space, there could be answers for all of us which go beyond our conventional everyday stuff that we tend to do. Music, for example, when discovered, can be a balm for someone who's struggling with mental health. And in a way, if you look back at the kid with ADHD, that's what he's managed to do, that he's integrated himself so well into music that it's provided him with an alternative identity, a way of positively viewing himself. And certainly that's a lesson we all have to learn, that, music, the arts, literature, community activities, religion and spirituality, your betterment could well lie in your engagement with those things, with one of those things, nature, farming, sport, something you've probably been interested in, something you've always wanted to do but you've neglected or never had an opportunity to do. Coming out of a mental health condition or recovering from a mental health condition can actually be probably facilitated by a positive hobby in that direction.
A lot of people today are being diagnosed with ADD and ADHD as adults. What is the trigger that needs to take people to a doctor to understand whether they have these conditions in adulthood?
Yeah. One of the things is a self-perception of inefficiency. I am struggling at work for some reason is very often the thing. And of course, mental health itself could give you that perception. So it need not be attention deficit disorder at all, but for many others it's much more latent it is. So I've had a lawyer tell me I can't listen to what the other guy in court is saying. I'm not able to comprehend it. I'm not able to process it. So I'm just standing there looking blank and I have no response. And that's what brought him to me. I have super smart guys working in the corporate world saying, but you know, I'm inefficient in this way. I'm not able to come to meetings on time. I'm not able to prepare for meetings adequately. You know, I'm not able to synthesize information in the way that I should, and so on. And clearly it's not my lack of intelligence. It's got to do with my not being able to focus. So people have different reasons why. And I think a lot of them today, at least the ones I come across, it's coming from the workplace, because our workplaces today are quite demanding. And I think the pandemics amplified it because, you know, in the past or pre-pandemic, you went to work. And the work environment in its own way supported you. So a colleague would say, hey, boss, you know, aren't you supposed to turn this in now? You know, or don't we have that meeting in half an hour? And when you're sitting at home and working alone, you don't have any of those environmental cues. And the lack of environmental cues mean you goof up a lot more. And you become more aware of your goof up. And I think the loneliness also amplifies those feelings. So I think it's a combination of all those factors. A lot of people with attention deficit are very distractible, so they thrive on environmental stimulation. And then that completely went absent for a couple of years, especially if you worked, you know, work from home type of occupation.
Right.
So I think that all that has also contributed greatly, as has public awareness. I mean, I think, you know.
If people are coming to you,
yes,
it's almost preventive, isn't it?
In many ways. And I think there's another thing. I'm very proud of the young person today, because they have no hesitation in walking in and saying, Doc, I've got a mental health problem, which was not the case then 15, 20 years ago. I mean, when I started practice, I don't think people would frankly come and tell me, look, I've been struggling. Yeah. It was always sort of all kinds of things, and then finally you would figure out what is going on, you know.
Yeah, yeah. And do you get, what is your percentage of men to women? Are men also coming in a lot more?
Oh yes, a lot of the young people who come in are men. So I think acknowledgement today from the younger generation, I don't see many differences in their ability to either volunteer to ask for help or come and talk about it. But of course, I think still with the our generation, I think it's still very much more.
That's right.
Yeah, it's probably more often the woman than the man who comes voluntarily. Yeah. The man has to be kind of brought in with a lot of persuasion. Yes.
Yeah. So that idea of masculinity is changing, therefore.
Oh yes, very much so.
Right. So we talked about this change in decades, right? How it's changed over the decades. What about diagnosing developmental disorders? Has that changed too? Is it easier?
I don't know if it's easier. What has changed it has become truly a lot more multidisciplinary today. You know, I think in the past, a lot of the work that people did was almost in a way unidisciplinary. It was quite silo. Today, people readily work in teams and they acknowledge the need to consult with each other. And that has resulted in children having, I think, with developmental disabilities, having a far more comprehensive, you know, view of their condition than it did in the past. That's one change. The other change, I think, is that we understand that neuroscience has a role to play. So our ability to use neuroscientific knowledge.
Previous episode, right?
Yes.
There is no magic pill
Unfortunately, no, and there is no ball that you're going to hit out of the park.
Yes.
So there is that challenge that it's long-standing work
Yes.
which we have to do.
But has there been any patient who has walked in with symptoms and you've not been able to diagnose it?
So there's this very interesting condition called somatization disorder. And somatization is when you convert a psychological symptom of anxiety or distress into a physical symptom. And how Freud described it was, he said the anxiety of the conflict in your mind is so high that you can't even begin to kind of process it or acknowledge it, and therefore you sublimate it into a physical symptom, right? In this type of problem, a person has multiple physical symptoms, but without actual physical cause, and they end up seeing different specialists. So atypical facial pain is something that people go to a dentist to, or a neurologist or an ENT surgeon, and then they hear there's nothing wrong with you after various tests. Okay. In the same way, people who panic and have anxiety attacks and have palpitations often end up with chest pain or often go to the cardiologist. Right. That's called atypical chest pain. Okay. There are people, both irritable bowels and constipation are often related to the emotional state of the individual. There is fibromyalgia, which some people believe is a condition on its own. Many people believe it is a type of somatization, a psychosomatic condition. So like this, we have several examples of conditions that befall us. And we had a lady who was actually the wife of a doctor, who for 2 years would feel hungry half an hour after the last meal, and then would end up eating another meal. And of course, she gained a lot of weight. Of course, she was pretty dysfunctional. Of course, she had to go to the loo several times a day, and she wasn't having a normal life at all. And her husband, being a doctor, she had had the best of diagnosis done. You know, she'd been to various specialists, various tests had been carried out, and everything was negative. I wrote about this in the Hindu magazine called What's Up Doc. And basically what it was that she had this psychosomatic condition where there was emotional stress, not very well acknowledged, not very well worked with. There were these autonomic symptoms because chronic stress had switched on the autonomic nervous system and caused what we call dysautonomia. And there were, as a consequence of that, a whole host of physical symptoms which she was struggling with. And finally, what got her better, very interestingly, was integrative health. What got her better was, one of the treatments we use is called mud packs, where we use river mud and create a pack over the abdomen. And that settled the bowels for her. She stopped having, these crazy hunger pangs that made her eat more and more and more. And so like that, yes, we do come across people who be fatalasa. But very interestingly also, there's a word of caution here that we need to be aware of. There's a very famous psychiatrist at the National Hospital, Queen Square, which is the mecca of neurology, where I trained in the old days. And he did a study where he showed that when neurologists diagnosed people as having hysteria, he took out 100 such case sheets and followed up those people to find out what happened. A very large proportion presented with a real physical cause later. So in a sense, one should never be in a hurry to label something as it's all in the mind, and one needs to try and understand the person as a whole. And to be quite fair, I think people who go through something like this are suffering. They also don't know what's wrong with them. And I don't think anyone wants to suffer. Right. So it's really a question of us helping them accept their problems a little better, work through their problems, and get symptom relief over a period of time. And psychological therapy can be very helpful in that. Something like TAVNS can be very helpful in that. And of course, as I mentioned, the holistic therapies can be very helpful in that. So there is hope for people with these unexplained symptoms.
Right. It's also a lesson to treat the body as a whole, right? And not as parts.
Absolutely. Absolutely. Because I think we live in so much of a specialist era that, one famous physician commented that you'll soon need somebody to count the fingers. And so, yes, from that perspective, that holistic view of an individual, body, mind and soul as one is very, very helpful.
Right. One last question. If you were to write a letter to your child who's at the cusp now of adulthood, what would you tell him about adulthood and about living life through your lens of a brain doctor?
So I think the first thing a child should be able to think and acknowledge is that life is not a walk in the park. Okay. So you are going to have challenges and obstacles placed in front of you. And I don't think parents should bring their children up to feel that life is going to be a walk in the park and you're always going to be protected in the way that we are doing it here for you. I think this is important. The second thing that I would like all youngsters to do, including my own child, is follow their dreams. So I don't think anyone should stop their children from following their dreams. And however obscure the dream is, it needs to be given wings. I think the role of a parent is a facilitator. You can of course facilitate the thought process. You have a responsibility to make your child think and think with your child. But it's very, very important in the context of our own aspirations that we don't end up becoming a party pooper for the child and her or his dreams. That's very, very important too. And the third, the people who succeed are not the most intelligent. The people who succeed are the most resilient and the most adaptable. And I think adaptability to all that life throws at you is one of the most important traits that you can encourage a young person to develop. Resilience, of course, but also adaptability. So, like Paulo Coelho says, be like water, flow around stones. And I think that this is something that we need to help our children understand, that life is a lot about emotional intelligence and life is a lot about resilience and adaptability.
Thank you so much, Doctor, for
Such
your
a
time.
pleasure. Thank you.